All right. Well, I have kind of a special cholesterol science series. This is actually going to be a little bit different because we're going to keep this a little less structured, but I'm very honored to be joined by Dr. Ethan Weiss, who, as I understand, you are a preventative cardiologist. Is that right?
I mean, self-proclaimed, yeah. There's no there's no board or anything. I'm a cardiologist, but I like prevention.
Now, what's fascinating is I actually have a tough time thinking of you as a cardiologist, and I mean that in a good way because you speak so much more like a very deeply trained biochemist. Uh, and now I've got to concede you're like my new favorite podcast.
That's very kind. I am also a self-proclaimed scientist. I never got a PhD, but I really like science. So I've spent a lot of my life in a lab.
Now, something that the viewer should know is we already have a little bit of history. We've had, I actually had to go back to when the very first time we had any kind of exchange at all happened. And it turned out it was on Twitter a year and a half ago. It was in like the middle of January at some point. And probably, I'm just guessing, but if you went a little more forensic from there, we probably got into some debates here and there. And then we kind of got into like this really lengthy debate that I won't bother recapping, but went on and on for quite a while. But as with, I think, a lot of your best friendships, after we kind of beat each other up for a while, we got into like some good, private discussions. And I've since considered you, without question, one of my favorite people in low carb. And I want to emphasize in low carb because it may sound odd. Typically, a lot of people feel like those people debating on the side a little bit more friendly to the lipid hypothesis are usually not low carb friendly. But let's correct the record up front in this discussion is while you may feel different than I do on some of these cases with the lipid hypothesis, you're absolutely a fan of the low carb diet. Would that be true?
All in. Yeah, all in. I mean, I have my own version of what I kind of would think might be the optimal low carb diet, but we can talk about that later too. But yes, I am all in. I am low carb. I've been in nutritional ketosis basically for the better part of the last year and a half myself, and big believer.
And this includes on the business sense. Feel free to plug your product real quick.
Well, yeah. So yeah, I don't want to plug it, but I want to acknowledge it as a conflict. I am a co-founder of a company called Keto, Keyto, and um, well, we can talk about it, but we have a device that allows you to measure acetone from the breath, but we're really trying to build um, a full end-to-end program to help people to basically help make doing low carb easier on people. And so I think we'll talk a lot more about that in the future as a company, but we believe in not just making a device and giving people information about whether they're in nutritional ketosis, but we want to help people know what to do, what to eat, what not to eat, and really kind of see ourselves as a nutrition company beyond anything else.
It's fantastic. Okay, so I got inspired. I actually made a special graphic just for this podcast broadcast, if you will. But to get to it, I'm going to need to share my screen real quick. And there we go. All right. Hopefully you can see it all right.
Right.
So pretty much we have two groups around the world right now. There's this occasion playing out over and over again. You've got somebody who's been on low carb, and they're actually quite excited about their low carb journey. In fact, they're probably really excited about their first blood work, which they assume, like I did when I was getting my first blood work, that's going to be great across the board. But then they get an awakening of sorts. They find out that actually, no, there is one thing that is concerning to the clinician, to the doctor, and that's that their total NLDL cholesterol has gone way up. And I'm going to kind of, through our conversation, sort of call this of those people who end up ultimately deciding that they would like to go ahead and continue with the higher total and LDL cholesterol. I'm going to call those the low carb cholesterol skeptics, of which I would kind of say that I'm certainly on the side of. Many who see their LDL go up on low carb, and many have a newfound skepticism towards the medical community due to prior advice appearing to be flawed or unhelpful. So they're already kind of on this different ground because Like me, I was, told fat is fattening. I was told meat would raise your blood pressure, all sorts of different things that I was used to from dietary advice growing up, that all of a sudden it feels like low carb turns on its end. But I feel like the skeptics don't always take into account where the clinicians are coming from, because often they're not as familiar with the blood work, and often they haven't seen total and LDL cholesterol at levels of many low carbers. And if I could even take it a step further, because I feel like this doesn't actually get brought up enough, I think that a lot of people, and this includes myself, who haven't actually spent time as medical professionals, we don't have a lot of the personal experience you do providing care, where we actually observe people before an event, to then observe what happens after an event, whether they survive or they don't survive, what effect that can have on their families and so forth. And so I think a lot of times there's not as much appreciation as to the emotional impact that should be respected, I think, on both sides of the fence. It's not just how much the patient cares about the gains that they've made. I think it's not just on the knowledge side with medical professionals. It's also that they genuinely have a deeper kind of concern that they have a lot of specific experience with. Wouldn't you agree?
Yeah, I think so. I mean, it changes the game. I always used to tell my kids that, like, if an experiment went bad in the lab and a bunch of mice died, like, we'd clean it up and start it over on Monday. But if something goes bad in the hospital, you make a mistake, you don't get that second chance. So it's a different level of stakes, I think, probably.
Right. And I think that that's something that's often missing from this part of the conversation. I've come to realize, really, I'm embarrassed to say, more in, say, the last 6 months than in the first 6 months, how much of an emotionally charged subject this is. Probably the more detached engineer in me has thought about it more in a detached way, where it's, there's the ins and outs and the levers to pull, but there's really a lot of buy-in, I think, at an emotional level that does kind of create a sort of fog of war, if you will, in this whole process of these two groups kind of trying to talk to each other. And I think that's been a big challenge with communication, because the reason I've been looking forward to this broadcast so much is we don't often have what we're having now, where a lot of the debating is going on Twitter, it's going on forums or on Facebook, and there's more of this distance between both sides. There's not as much face-to-face communication. And I wish there were more face-to-face communication, especially between people of these different groups, in a more meaningful and constructive way.
Yeah, I mean, the truth is, Dave, I'm used to having these conversations. I've been having these conversations with patients for the last 10 years or more. I have a lot of patients who are very skeptical of the role of cholesterol in cardiovascular disease and skeptical of statins and other cholesterol-lowering drugs. And so I have this kind of conversation a lot, face-to-face.
And actually, let me follow up on that then. How many do you feel reach a decent level of expertise, especially in things like, lipidology and cardiology and so forth?
I don't know how you define decent level. It's very easy to get a superficial understanding of what's going on. And I think sometimes you can be fooled into thinking that science is simpler than it actually is. How many? I don't know. That's a loaded question, Dave. I don't want to say something I'm going to regret. I think very few.
Don't.
I have a patient who brought me, this is just an example, a patient who brought me this, which I don't know if you've seen. It's
Oh
called
yeah, I have. Well, I'm not sure if I've seen. I think I may have seen. There's a second one. I think
This
I
is
may have
the
seen
second
the
one.
first one.
Yeah. But no, I would say most of them are internet savvy. They're not dumb people. These are smart people. And I don't ever come at this from like, I'm smarter than you are, I know more than you do. And frankly, this is as good a time as any for me to tell you my philosophical approach to caring for patients, which is, my job is not to tell you as my patient what to do. My job is to inform you and have a dialogue with you. And if at the end of the day, you decide, as many of my patients have, that they don't believe this and they don't want to take cholesterol lowering medications even after a heart attack, that's their decision, and I'm not going to judge them or tell them I won't see them or I don't want to have them back. I've had some amazing relationships come out of that, those kinds of sometimes frustrating conversations.
Ethan, this is a safe space. You can be as blunt as you want.
No, listen, I mean, it's a fascinating thing, and we could talk about this forever and ever and ever. It's fascinating.
Well, actually, this is a good segue. Is I sent you the two blurbs that you had sent me in the course of an email exchange. Would it be okay if I showcase those?
Yeah.
So before showing it, while it may come off to many people who are watching this as somewhat critical, I want to emphasize that this was absolutely in the spirit of a very constructive, very excellent email exchange that we were having. Let me go ahead and share real quick. Back again. So this was, you had offered two things. This was the first few sentences of each one. You said, you sometimes seem to have made up your mind already, or at least you seem intent on disproving the lipid hypothesis. At the very least, I try to reframe the conversation as exactly what it is, which is an attempt to understand the risks, benefits of changes in lipids due to nutrition. I actually think that's very well written. I think your advice is well taken in this regard. And it really got me to trying to think about how best to balance these two sides of a fence that I have to kind of straddle. See, on one side, Ethan, I'm trying to advance a conversation. And there's only so far that I can take things when it's just a matter of talking points getting flung from one side to the other. So you've heard of Magic the Gathering, the collectible card game?
Yeah, of course. My kids used to play it.
I often feel like the studies these days are like cards in a collectible card game. You've got your collection, you know, the skeptics have their collection, and then it's like, oh, well, but what about this study? Haha. And then it sort of feels like it's almost a game of playing off the level of saturation that exists out there right now. And I'm always trying to find a way to next level this, to really kind of get deeper into the mechanics of it. But I find that that's a bit of a challenge, particularly when I feel the other person doesn't think that I'm an honest broker, which I can understand is a problem, right? And this is kind of what you were addressing with that sentence, right?
I think what I was addressing with that sentence is, I think you're going to have a hard time finding people. I mean, look, I'll have the conversation with you because I do it all the time, but you're going to have a hard time finding a lot of people who will be willing to admit that they believe the lipid hypothesis as a broader element is wrong. And I think you would have a hard time finding people who are going to be willing to believe they will reject that. I think all of us as scientists understand that science moves and that there are certain things taken as fact that then are later found to be not true. So I think everybody understands that there's some probability that the lipid hypothesis is wrong. I think most sort of mainstream scientists and physicians probably put that at an exceedingly low number. But what I meant by that, what I said to you in that email was, I think there's much less certainty around what are the effects of lipid changes that occur in individuals who go on certain diets, say a low carb, high fat diet or a diet high in saturated fat. What are the long-term effects on an individual's risk of disease, especially when you start to weave in all of the many benefits that might offset the risk, even if we sort of just allow that the rise in LDL carries some risk. I think what I'm trying to say is I think what we have is a tremendous amount of uncertainty around that question, whereas I think most mainstream physicians and scientists would probably believe there's very little uncertainty around the former position, which is the sort of what is the role of lipids in cardiovascular disease as a bigger question. Does that make sense?
Yeah, so let me see if I can rephrase that in a way that I think I'm interpreting it. There's a lot less certainty in, say, for example, the benefits that you may have observed in low carb patients where, you know, their blood pressure goes down, their HDL goes up, and their triglycerides go down, their insulin goes down, so less hyperinsulinemia. These are all actual cardiovascular disease risk markers, not just all-cause mortality, but cardiovascular disease risk markers in particular. And here we have a list on one side of the ledger, and then we have LDL on the other side of the ledger.
Exactly.
And so there's certainly, I think, a lot of people who would agree with you if this is where you're coming at it from, that are even low carb doctors who would say, you know, I am kind of uncomfortable with higher LDL, but I feel like that was a decent trade-off for what I see are these other risk factors that have now gone to a much better direction. Would that be a good retelling of it?
That is, and there's a secondary, more nuanced part of that story, which I think, and maybe even a tertiary one, but the secondary one is maybe the changes in LDL that occur. I think this is something you're very interested in, Ron Krauss and others are interested in, but maybe the changes that occur in this broad bucket of things we call LDL that occur as a result of changes in nutrition, like low carb and high fat, maybe those don't carry as much risk as, say, LDL that's increased genetically or for other reasons. And so maybe that can even be discounted more. I think ultimately what we all agree on is we're in sort of a relatively data-free zone here. I think no matter where you put your flag, I think we all agree that we need to do a lot more work to understand this really important question. And there are many of us who I think share a passion for wanting to understand this really super important question. So I don't believe the book is written on this. I think there are fascinating and important scientific questions to be asked and answered in this area. Where I think things get problematic is when we go back into kind of re-exploring the origins of the whole lipid hypothesis back to, however many decades ago, and Brown and Goldstein and all the other things that I think most of us will probably take as fact. I think we're all open to believe, I shouldn't say we all, we'll even say Catherine, I don't know if you listened to that one yet, but I highly recommend you listen to that interview because he and I talked about this kind of very thing. And while SAIC did what SAIC does, which is to say there's a linear relationship between LDL and risk, he did allow that there are potentially beneficial things like weight and blood pressure, other changes in lipids, insulin, other things that occur in people on low carb, high fat diets that may offset that risk of LDL. I don't think SAIC believes that there might be non-risky LDL, but I think maybe Ron does, and I believe I don't have any way of saying that there isn't. So I think it's a question that needs to be answered.
Can I, because you really just kind of opened up, this is working great because it kind of makes a perfect segue to the next aspect of it. Let me actually, let me just show you two quick slides that relate right back to this. So this has been, I tried to figure out the best way I could kind of brief this up in a couple slides. And I actually had this in a recent presentation, but it really kind of cuts to the heart of it, which is I absolutely do believe there's such a thing as pathologically high LDL cholesterol. And a good example would be, for example, immune response. But in fact, you probably are aware there are many different groups that will insist we're actually observing a higher LDL as, say, chronic inflammation, that this is ultimately being goosed to some degree by the immune response in play. Whereas there's also pathologically low LDL, which we know can come from many different forms of cancer, as just one example. The question is whether this right side of the screen is correct, and is obviously very central to my research because it comes back to metabolism. Is it possible that people on a low-carb diet who are seeing high LDL, who are otherwise seemingly metabolically healthy, have the higher LDL because they're trafficking direct fatty acid delivery? And then, of course, this conversely seems to show up with those people who are high carb, low fat, if they're powered more by glucose and thus more specifically by carbohydrates. Is that why we would observe lower LDL? And that leads to that. This is really just the central question. When cholesterol is elevated for a metabolic reason only, so we can rule out the pathological reason for why LDL is, then does it pose the greater risk? And I would posit that right now, this is the driving part of your comment that came from before, is that I was focusing a lot more on this metabolic question. Then I sought to find out if in the existing literature and the existing data, we can find at least close enough corollaries. I mean, obviously there's just not that many, for example, lean mass hyperresponders in the existing literature. That's a brand new phenomenon. But were there at least people who seem to fit this profile, this metabolic profile of possibly being powered a little bit more by fatty acids, even if it was more of a mixed diet than you would typically see under keto? And then would that have commonalities that we could see in a basic lipid profile? And that's why I started seeking this triad. And by the triad, you're already familiar with it, but for anybody who isn't, I'm talking about specifically high LDL cholesterol, high HDL cholesterol, and low triglycerides. And I sought to find where it is that anywhere and everywhere where I could find this triad showing up in the prior data. And honestly, this is the biggest single point of frustration that I've had since starting this whole journey is I came from technology where we're just awash in free data. I mean, there's just all kinds of massive data sets for everything. And I'm over here on the medical side, and I'm like, isn't there just a lot of anonymized available data for, lipids at large scale that I can look at against cardiovascular disease and mortality? It turns out no, like that's actually very difficult to get a hold of. But it's something that's definitely meaningful to me because I think it does relate back to this question of whether metabolically high LDL is in fact risky.
Yeah, that's the $64 million question. I think, let me ask you a question, and this is rhetorical but meant in good spirit. Do you believe that it could be?
Do I believe that it could be risky?
Yeah.
Yes.
Yeah. Okay.
Yes, definitely.
And so if you turn around and come back to the conversation we were having at the very beginning, talking about doctors, do you understand a little bit of the unease of doctors in thinking about this as a hedge, in that there's unknown unknowns, right? We don't know.
Yes.
Now that we don't know that metabolically, let's just call it metabolically elevated LDL. I can't tell you that it's as risky as LDL that happens for non-metabolic reasons, but I would believe that there's a possibility, maybe even a good possibility, depending on where you come. And so the question is then, what do you do in the meantime? Because you're not going to find out, you are not going to find out for 30 years or 20 years. And when you find out,
I think we can find it out faster.
No, I'm not talking about the studies that we're talking about potentially doing. I'm just saying, if you're an individual person and you decide that you want to discount the risk, right, which is everybody's right to do. Let's back up. I have people who discount the role of LDL in cardiovascular disease everywhere and refuse to, it's the wrong verb, decide not to take a statin even after a heart attack. And that is an unsettling feeling for me. But again, they're autonomous, free-thinking adults, and I don't run a jail. So they are fine to do that. I think I have less unease around this metabolic LDL question, but there is still some unease about it. I mean, I'll be totally honest, like I do not like seeing people running around with an LDL of 350 or 400, no matter how it got there. That is unsettling to me as a cardiologist. But I also can separate the two and understand that we don't have as much information there. But I will come back to this thing, which is the reality is, if you're an individual running around with an LDL of 350, you're going to make a decision. You have to make a decision that today that's going to impact you in a relatively long period of time. And by the time you get the answer, it may be too late. That's part of how I kind of think about this.
Yeah, and let me first of all agree. And if you probably don't see all the content that I ever do, almost nobody does. I don't, and I get tired of hearing myself, believe me. But I do try to take as many opportunities as I can to say what I'm going to tell you now. And I've been on record for saying it many times over, which is I don't believe, I push back when people feel like their doctors are stupid or they're uneducated, or like, I believe your doctor means to do right by you. In fact, you know what? Actually, I have a video about this in my queue from like a few videos back. But I believe that even the doctor who you meet who loves to, prescribe a statin to everybody strictly for preventive measures, they're like, I wish it was in the condiments. That doctor isn't just anxious to collect their stipend. That doctor genuinely believes in the tool set that that's the best thing that's for their patients and means to do right by their patients. They really do believe that. I get frustrated because I know there are some people out there who absolutely feel that there's a genuine conspiracy out there that's, meaning to keep us sick, that even the doctors are part of this interplay process to where you stay close and connected into the system. It's not many people, but for those people, I don't feel like they should have as much influence as they do to advance this perspective, because certainly I feel that by and large, almost everybody who's in the medical field, they've at least entered the medical field with every intent to heal and to cure people and to help out. And I do wish that there was more attention paid in that regard. So no, it's understandable why it is that there would be this shock, particularly when you've just gone through 8 years in medical school, 10 years, et cetera. You've had all of this time, and you're around 99% of other people who feel likewise and who have gotten the same training, and it's in the guidelines and so forth. And then all of a sudden somebody shows up and they say, I've heard some things on the internet and now I'm just not so sure you guys are right. I can understand why that would feel a little bit like an affront, and particularly if you're coming from a place of caring about their health outcome.
Yeah, I don't think it's an affront. I mean, so first of all, thank you for saying that. I also believe that obviously there's some bad actors. There are bad actors in everything. But I think most of the people that I've met in my now, I don't know, 28 years around hospitals, longer really if you count the time as a kid following my dad around. But most of the people are really well intentioned, and I think that that's important to kind of remind people. Sometimes people are misinformed, and as I said earlier, we're all collectively misinformed from time to time. We all make mistakes. We all kind of tend to get caught up in this herd mentality, and sometimes that ends up being revised, or the evolution in data happens, but we all learn to be humble about what we do and what we don't know. But I think most people are well-intentioned. I don't think that most of us feel that it's an affront, or that there's somebody showed me once, like or maybe even somebody bought me a mug that said something to the effect of like, your Google search is not as good as my MD, or something bullshit like that. And that's nonsense, right? Like I think people are more informed today and better informed today than they ever have been when it comes to medical science and everything else. There's so much more information out there. I think people are also genuinely confused, and I think we doctors are also pretty confused from time to time. But I do think there's I wouldn't call it an affront, but there's a concern, and maybe you could say it's paternalistic, but I do think many people feel a sense of unease and concern when a patient will come to them and do something that defies logic in their head.
Certainly. And look, here's where I'm going to kind of turn it around the other direction. The one issue that I've had, probably one of the biggest ones I've had, especially over the last year, is that I've really, really taken a lot of time to try to meet with people outside the low carb community that are specializing in this field, particularly lipidology. And I find there's a surprising lack of curiosity, particularly with this phenotype we're talking about with lean mass hyperresponders. If there's actually a phenotype that emerges from the diet that results in this extraordinarily high level of LDL, and it has these other things in common that we don't observe very easily anywhere else in science, particularly if that would normally be associated with a risk factor we're watching so closely. I genuinely and really quite naively thought this whole time that it would explode, that there would all of a sudden be 10 different PhD teams on top of this, and that it would become something that might, garner enormous attention. And I figured it was just a matter of time. It's just a matter of getting it in front of the right people. And now I'm honestly a little less optimistic about that than I ever have been before. And it's a bit of a problem, in my opinion.
Don't be less optimistic. There's more. I can tell you as somebody on the inside that there's genuine interest and curiosity about this subject. Again, as I said, I don't want to belabor this point, but I think if you come at this, and this is me being my typical asshole. So if you come at this as the lipid hypothesis is wrong, everything you've done over the past 35, 40 years in your career is wrong, you're probably not going to get very far. But if you come at this from the standpoint of, hey, look, set aside all that. Let's focus on this one very interesting question where you have, as we've laid out several times, you have LDL going up at the same time as all these other things are improving. And you also have demonstrably a different looking LDL, right? I mean, everybody agrees it's a different looking LDL. So it is purely plausible that the risk associated with that level of LDL, as we've talked about before, in somebody who has familial hypercholesterolemia versus somebody who's, as you've termed them, lean mass hyperresponder, it's fully plausible that those risks are completely discordant. And I think until we know the answer to that question, we can't say that we do. That's fact. And I think many of my colleagues agree that that's a really interesting question. The other part of this that I mentioned before is, what do we do in the meantime? And that is, to me, a more complicated one. And I struggle with that. I'll be honest. I do struggle, because it is at those levels, uh, it generates a lot of fear, I guess is probably the best word.
And honestly, I think that that's perfectly understandable, and I would argue healthy. I think that I think that a lot of people assume, and this is kind of one other thing I really want to get out in front, is a lot of people look at my research and they oversimplify it, or they look at the things that I'm pushing back on that I feel need more, I guess you could say, I don't know if I want to say arguing against, but certainly I am the consummate skeptic that in many ways is playing the defense role of the lipoprotein, because I feel like there's so many amazing things about it. And I feel like a lot of times it gets sort of disparaged in the reverse role of sort of a prosecution. Let me kind of unpack that a little bit.
Okay.
I feel like in order to advance the conversation, it's not as simple as to say, hey, what if it's possible that lipoproteins are part of the innate immune system? Like, that's actually already in the literature. But to actually take it a step further than that and say, well, this is actually a good reason that we may want to consider all-cause mortality when looking at lipoproteins. Already, I start getting pushback and sort of dismissiveness in that aspect unless I actually take it a step further and get so far as to say, get a hold of the NHANES data and crunch the data for myself to see what that association level is. Now, as you well know, a lot of people will then sort of push back and say, well, this could be reverse causality. You may actually be capturing the death rates of people who are already near death, which is why their LDL is lower. That's fine, but it took me kind of coming at it from a position where they would consider me the consummate skeptic in order to then feel a little more buy-in to advancing the conversation further to allow me to get to the next step. Does that make sense?
It does. It does. And I know that you love to talk about all-cause mortality. And look, I love it too. If you go back and read my however 50,000 tweets, you'll see that there was a long period of time where pre-approval of PCSK9 inhibitors, I made a very strong argument that we should not approve them until we have outcomes trials, because we've made mistakes like this in the past. I think hard outcomes are really important, but the absence of hard outcomes doesn't mean that they don't exist. I guess the fact that trials aren't powered as to a degree that we would like to see them powered, say to look at for differences in all-cause mortality, doesn't mean that there is not a difference in all-cause mortality. I think that's a really important thing that we should state clear. The absence of data is not data. And so, yeah, there are much fewer than I would like, trials in cardiovascular medicine that are powered to detect changes in all-cause mortality. Scant few. Is the reason because there is no change in all-cause mortality? No, the reason is because it's economically infeasible, or I would say unattractive, for the companies to carry on studies that would last as long as they would and would have as the number of participants they would. So for me, it's a purely economic decision and non-scientific one. And I'm disappointed by it. It would be great if we had more. We don't.
I will. This is one place where we're definitely going to butt heads.
All right.
But let me put it to you this way. From a statistical standpoint, can we detect whether or not one group has died less of one thing, while in fact that one group that's died less of one thing is in fact, given enough time and enough power, dying more overall? And the answer to that's yes, right? You can power a study enough to determine one group's dying less of cardiovascular disease in particular. But you can't, if you don't power it enough, you can't detect whether or not they may be dying more overall, given enough of a size of the sample and enough time, et cetera, right?
Yeah. I'm not sure I'm following.
So in other words, is it possible that a drug can reduce the rate of death of one, like cardiovascular disease? You have less cardiovascular disease. So the other group has more cardiovascular disease. But the intervention group actually, if it were 10 times the size, would prove that it actually has more overall mortality, and therefore they're dying more than the placebo group.
Yeah, so I have two responses to that. One is, and I know where you're going. So one is, yeah, of course. But two, I mean, still far and away the highest causes, the biggest causes of death in the developed world cardiovascular disease. I mean, but far and away. So of that, chunk in the denominator of all-cause mortality, there's a big portion of that that's cardiovascular death. So I don't think we're off. And I do think there are enough hints from the few trials that we're actually adequately powered to detect differences in all-cause mortality. And from human genetics, I think there's enough of a hint that we're not missing this. This conversation, Dave, actually is exactly the same conversation that happened in the early 1990s when I was a medical student before 4S came out. And there were a lot of people who believed that statins might reduce the risk of heart attack because of their effects on lipoproteins. But there were an equal number of people who were terrified that statins would cause people. I mean, there were stories about statins causing an increase in the rate of suicide, cancer, I mean, everything you could possibly think of. And so I think when 4S came out and showed, it really settled people's fears that there was going to be some big signal of something else. And in fact, if you go and you look at the now hundreds of thousands of people, and I know you hate statins, or statin trials,
No,
but
no.
if you look at the hundreds of thousands of people that have been randomized to clinical trials on statins, there haven't been big signals of tox, right? I mean, I think we all agree there's a very small but real effect of increasing risk of diabetes. There's a lot of debate about neurodegeneration. It's never shown up, as far as I can see, in anything close to a real signal. There's never been a signal on cancer. And if anything, the sort of pleiotropic effects of statins suggest that there may be benefits in reducing other diseases in addition to cardiovascular disease. So I don't think, I think I'd be very surprised if statins were causing a decrease or an increase in all-cause mortality, despite all these other things we know about. I don't think there's some hidden magic out there.
I'll say this, because as you know, I don't normally dance into the statin soup. I've always tried to be mindful of it, but it's not so much that I have a dislike of statins. I think a better way of putting it, here's a good way of putting it. Statins may be the best thing in the world. They may be the worst thing in the world. I actually don't know. My problem was—
They're not the worst thing in the world.
They're not the worst thing in the world. Yes, we know worse things. The point is, my problem is with the collection of the data. It's the statin trial data. It's necessarily and understandably, it's got a degree of selection bias. It has to, because it's industry driven. It necessarily needs to be. That's not a conspiracy thing. That's an understandable. Why would you take products to market that are failures? You wouldn't, right?
Well, they do it all the time. I mean, they don't take them to market, but they take them to phase 3 clinical trials. And we have lots of examples of phase 3 clinical trials that blew up and were unexpected duds all the time.
So of the data that we've collected where LDL was lowered, but mortality increased, how much of that ends up in the meta-analyses?
LDL was lower, but mortality was increased. So you're talking about like
a failed drug trial. Would a failed drug trial make it into the meta-analyses?
I don't know. I assume so. Why wouldn't it? I mean, it's anything. I mean, I don't do meta-analysis, so I can't speak as an expert. But if you're going to do meta-analysis, you can't cherry pick your favorite data to go into the meta-analysis. You got to include everything. I'm not a huge believer in meta-analysis, by the way, Dave. I don't love them as a mechanism to do science. I think they're very fraught with potential bias.
We're in great agreement on that. Okay. I'm not a big fan of them either.
But I'm not even talking about that. I mean, there are a handful of.
But you've already agreed with me, for example, on run-in periods. Run-in periods are another way by which a trial is unfortunately starting off on a foot where it's potentially going to reduce what would be the perceived side effects. Right?
Of course, which is all the more reason why I think Daryl Francis's study, whenever it gets published, is going to help us understand the effect on muscle-related side effects. I think we're far from complete on that story because of the run-in period, but I doubt a run-in period is going to alter the all-cause mortality. I doubt that we're killing people in 30 days.
But there's another major factor. There's the ability to arbitrarily stop the trial and then take it to market. The arbitrary stoppage is one of the biggest problems I have.
It's not arbitrary. It's actually, all those decisions are made by DSMBs. I mean, I don't think the pharmaceutical industry as an industry is like the greatest thing in the world. But I think, again, when we come back to discussing like the intentions and quality of the people, and I know many of them, these are all really good people, all well-intentioned people, all want to do well. Not all, most of them. So I find it very hard to believe that there's a vast conspiracy among this entire industry of people to harm people. I think these people actually really do want to do what their mission is, which is to help improve human health.
And I agree with all of that. That's why I don't like even bringing up these aspects that are the problems with statin collection of data, because often it becomes, and you and I kind of got into this one other time where I said, I don't want to end up in the false dichotomy that often happens with discussing drug trial data. Because I agree with everything you said. I believe everybody is as well-intentioned as they can be in the execution of this. But of course, why wouldn't a drug company do a run-in period? Why wouldn't
Okay, what about an NIH-sponsored trial, or what about a NHS-sponsored trial? So, and again, I'll grant you that the run-in periods make understanding the muscle-related side effects of statins complicated and difficult. And I think there's hints from things out there that suggest that it may be bigger than it actually has been reported, but we'll get the answer eventually. There are studies ongoing that will answer that question. I very seriously have a hard time understanding how a 30-day run-in period is. I mean, unless you really think the LD50 of statins is I don't know, something significant, that we're killing enough people in the run-in period to actually make it, I think we have seen that signal.
Right. Again, and this is why I can't emphasize it enough. I don't know. It's my complaint is more with the collection of the data. It's less, I don't really spend a lot of time talking about statins in social media or anything. I've never told anybody to go on or off statins. I try to be as agnostic as I can.
What's your problem with the collection of the data? I'm curious.
I would actually love if there were non-industry studies on statins.
There are.
What are you talking about? I want large scale follow-ups. I would love a 10-year trial on whatever the existing prominent statin is of the day, and for it not to be run by industry, and for the trial period to be fully complete, and for there to be no run-in period. That alone would already cover quite a lot.
Sure. I don't know. I'd have to go back and look, but I'm pretty sure the heart protection study was an NIH-sponsored trial. I have to go back and look at them. But there have been, the NIH does sponsor drug trials from time to time. They've done it more in the hypertension space. They've done it at least twice there with Sprint and with AllHat. And that, by the way, those two trials, actually, particularly Sprint, got criticized more than any drug trial I've ever heard. I mean, that trial got lambasted because of decisions those guys made to do things in a certain way scientifically. So I off the top of my head, can't remember them, but I'm pretty sure there have been government-sponsored statin trials. And again, the only reason
I asked about that. And maybe I just got bad information. My understanding is there was really one major large one, and again, I have not addressed on statin data in a while, so I'd have to look it up and probably give it to you after the podcast. But and that one didn't provide surprisingly good information on the statin side of it. But again, I think it really would help the public relations of statin trials themselves if that was a little more of a predominant and common circumstance, that these things would actually be run by
I know, but that's not the way. We barely have money to fund the science that we want to do. And I mean, that's just change, that gets into kind of how we redesign the entire system. We happen to have a system where these drugs are being developed in corporations, and that those corporations have a vested interest in seeing that their product, does as well as it can do. They obviously also have a vested interest in seeing that their product doesn't kill people. It's bad when that happens, and it's bad for them then when it happens. And I really believe they don't want that to happen. I believe there are plenty of examples where they've done things that were greedy and dumb, and we can all point to them. I think the Vioxx story is a great one. But anyway, yeah, so a heart protection study was definitely a government-sponsored statin trial. But in any case, I think the gist of this is that maybe the other thing to do now is to kind of come back to why many of us, including me, feel so strongly about drug trials, because I think you know that, but I just want to make sure that we explain that to everybody else. This is not just me trying to make money for my friends in industry. There are reasons why, when it comes to looking at the quality of the data and assessing sort of what does this mean, there's a reason why many of us are drawn towards these placebo-controlled, randomized controlled trials, right? I mean,
Right. Well,
you get that, right?
yeah, 100%. Well,
Yeah.
actually, this kind of sets up the perfect segue. Let me switch on over to the one question that I was mentioning from before. So what the tweet was referring to, and let me give proper credit. This comes from Eric Rogers. And this was a post hoc analysis of the 4S trial. And this too, I haven't seen this study in a little while, so I'm not sure how I can quote this, but the graph effectively brings it out. This actually had the triad in play, where you can actually see between the placebo arm and the intervention arm that the placebo arm that had, let me just go and read this, effects of simvastatin on event-free survival by subgroups defined by baseline HDL-C and triglycerides. Event-free survival was significantly lower in lipid triad patients receiving placebo than in other treatment subgroups, and improved more with simvastatin in lipid triad subgroup than subgroup with isolated LDL-C elevation. So these hollow round dots that are over here, this is basically those people with the triad. In effect, statins weren't helping, or let me put it this way, they were doing as well as if they were on the statin for the control group or for the intervention group.
Okay.
So let me ask you this straight up.
Okay. Wait, can you leave that back? I want to.
Yeah. Hold on one sec. So let me ask you this straight up.
Wait, hold on. I'm slower than you are. So event-free survival is significantly lower in lipid triad patients. Lipid triad is HDL. How is it defined?
A positive HDL.
High HDL, low triglyceride?
Yes.
And LDL is they don't care?
I don't know. Again, I've got to get back to the study. I'd have to check.
Because again, if you want to be super formal about this, we're talking about LDL, but really the marker that matters is non-HDL cholesterol. So, I mean, I think we're actually probably talking about the same thing. I mean, it's
that HDL cholesterol doesn't matter for the.
Well, I don't believe that HDL cholesterol matters formally, causally. At least we haven't shown it in anything that I've seen. But what I'm saying is the marker that I think is the best predictor of risk is not LDL-C, which is calculated by the Friedewald equation, but it's non-HDL cholesterol, so total cholesterol minus the HDL, because that includes all the ApoB containing particles, including LDL cholesterol and triglycerides.
Remnants, right?
Yeah, and triglycerides and LPA. So I think that's been shown again and again. Now you'll get some of these lipid people like Tom Dayspring and Alan Snyderman suggesting that that's not sufficient, that you need to measure ApoB or LDLP. That's a more nuanced conversation, but I think most people agree that the best marker, the ideal marker, is non-HDL cholesterol. And there's been some discussion of trying to reframe that as the marker that we all follow. The problem, of course, is that everyone's been following LDL-C for 30 years.
So I actually want to return to that, but before dropping off of this,
okay,
if that's true, if high HDL and low triglycerides in a strata show that a statin would not benefit them, you would consider that to be very important information for us to know before deciding to prescribe it, right?
Yeah. So you're saying if the patient came to you and they had high HDL, high LDL, and low triglycerides, and if there were a trial that had shown that statins didn't work in that population of people, that would be important to know. Is that what you're asking?
Yes. You likely wouldn't treat them if the placebo arm of those trials didn't.
You don't want to treat people if they're not going to derive benefit from the drug. Yes.
Okay. So then, so here's my direct question. The reason why I have a problem with statin data. Right. Why is this 15 years old? Why has there not been more? We already have plenty of data from plenty of trials since 15 years ago. It may be longer, right? Wasn't 4S like 20 years ago?
4S was 1994, yeah.
Yeah, 20 years ago, almost 25 years ago.
Yeah.
Why in the world, if we've identified this then, that this might have been a low-risk group, why wouldn't we have at least wanted to confirm or disconfirm that this was a regular, non-benefit group?
So that's a great question. And that speaks to, I think, a real problem in doing these kinds of trials, these kinds of studies, which is that the drug companies have no reason to make their market smaller. So that's actually a
That's
reasonable.
exactly right.
Yeah, no. I grant you that the trial is not going to be sponsored by a drug company, right? Why would they ever want to make their market smaller? And so then that raises the question of who could possibly afford to do a 30,000 person 5 to 7 year trial where you stratify people by their baseline HDL and triglyceride levels. That look, I'm not saying that that's not an interesting trial to do. The problem is it doesn't exist, and I don't see an easy way for it to get done unless you find a billionaire who wants to sponsor it.
Right. And look and listen, right at this moment in time, if I was the stalwart skeptic, I'd be like, and that, Ethan, is why we should just ignore all that data. And I'm not saying that. I'm saying quite the contrary, that the thing that makes me cynical is not these setups for how these trials happen. The thing that probably feeds the hardest part of my cynicism is that this wasn't just discovered last year. And now there's a new push on the scientific community side to try to identify this low risk population.
I know, but I think you're probably underestimating you're underestimating the challenges that would be associated with doing the trial that you describe. I mean, these are humongous trials, and they take millions and millions of dollars, and they're done across multiple countries and continents and institutions. I mean, again, this one that I'm looking at, heart protection, is 20,000 UK adults, 20,536. So, I mean, these are not like, hey, let's put together, like a Kickstarter campaign and see if we can get this done. So I think there are probably a lot of scientists out there who would love to get the exact trial that you just described done, but that it hasn't been done doesn't mean that.
But why can't we do further post hoc analyses of the other trials?
Well, you'll have to go speak to people who understand statistics a lot better than I do. But the post hoc analysis world believes that post hoc analysis is post hoc analysis. So, and I think you see this a lot more in cancer trials. And I'm not a trialist, so I'm not going to speak to it. But I think predefining and specifying your endpoints is incredibly important because of the multiple comparisons problem, the Bonferroni correction problem. That is, if you looked at one outcome and you have a power to have an alpha of 0.05, p less than 0.05 as being there's a 95% chance that a true positive that the result you get is actually real. If you do that over and over again 100 times, you're going to find 5, right? So that's part of the reason why they ask you, or the statisticians force you to correct for multiple comparisons. They have multiple hypotheses. So whenever you do one of these post hoc things, you have to be cognizant of the fact that it wasn't, that the trial wasn't designed to do it that way. It doesn't mean you can't learn something, and it doesn't mean that it can't be hypothesis generating, but I don't think it's going to be practice changing.
I think it's, and I fully concede that we'd be wanting to go towards the direction of hypothesis generating. I'm all for hypothesis generating, particularly if the data is already resident. If you already have like these massive databases that exist that have all of that data in hand, why not at least have access to people who can independently detect that? And that's
I don't know how to answer that. I think that's going to change. I have a strong suspicion that there's been a big change in the way that we all have to agree to share our data, and even the drug companies are going to have to share their data. I believe that problem is going to be solved going forward. Whether you'll ever get access, whether you're ever going to get access to the old trial data, that I probably guess doesn't happen.
No, I'm so glad you said that, because I don't know how much you follow me on this, but I am such a staunch advocate for open data.
Yeah.
We're doing these blood testing drives. We did one in San Diego, and we're going to do another one coming up in Houston. And I've asked people if they would opt in to allow us to make their anonymized data available as a straight up data set. And I'm very thankful for everybody who's been able to sign up thus far. And we're trying to do more and more of that. And I want this data to be easily available. One of the things that frustrates me as a technologist is I really feel like we on the technology side could help you guys on the medical side if more of this data was available for us to do machine learning against. Because I'll bet there's all sorts of things you guys have never imagined, or we couldn't have imagined, but an AI could have picked up and started to detect different sorts of patterns and things that we can actually make better use of. But it takes getting to the point where there's more data sharing. I mean, it's strange to me that you have such a small group of people that are stewards over millions, billions of dollars worth of data that for which there's so little analyses applied at any given point. It's frustrating.
You will not get an argument from me on that one, Dave. I think you're right. And I do think that sort of ship has sailed. I think people are now going to be forced to. Now, there are concerns about privacy, especially when it comes to the power of AI and de-identifying or re-identifying de-identified data, right? I mean, there are ways that you can now, I've been shown, can kind of take a de-identified data set and actually re-identify who the individuals are. So that is a separate conversation, but I think in general that requirements for data sharing have changed a lot in the past 4 or 5 years. I think we're going to see that continue. So I think you'll have access to tons of data going forward.
Yeah, and let me actually double check on this. Isn't it true that there is a common practice with anonymized data for which some parts of the data get slightly modified so as to kind of skew it in a sense to make some portions?
I've heard that there are things you can do. I haven't actually done it, but I've heard that you can like take everybody's birth date and make it the first of the month. And there are other ways, you can do things that make it harder to re-identify people. But anyway, I think the power of this technology is amazing. And I think if it's used thoughtfully and carefully, that it's tremendously exciting. So I'm looking forward to seeing what happens when people like you get their hands on big data sets. I think some of it is just hoarding, and some of it is, just protecting people's, empires, but some of it is also legitimate concerns over privacy.
So let's go ahead and return back to non-HDLC.
Okay.
Something really fascinating happened, I want to say a few months ago, and I was calling it at the time real-time science because having the NHANES data in hand, I believe it's Dr. Tro who brought up in non-HDL again, and I realized that I had run all of these things against LDL, and not only that, the calculated LDL, so it was Friedwald, but I had never done non-HDL. And so I'd ran non-HDL against those people 50 and older. And indeed, I found a stepwise increase in mortality when non-associated, when not having any further qualifier to it, right? But here's where it gets fascinating. And, I'll see if I can actually link it in the show notes below in this YouTube, but I'll share it to you a little bit later. When we dropped the triglycerides to under 100, it flipped to where actually the higher and higher your non-HDL went, the better your all-cause mortality, the lower it was. And it was also stepwise, which really does seem to further back up that this may really come down to remnants, triglyceride-rich lipoproteins. The greater presence and likelihood of those being in your bloodstream is itself a very bad sign.
Maybe. I mean, I'm not a huge fan of like chopping and dicing old observational data. I know you love it, and it's fun to go and analyze the data set. And it's the only one you have, but I'm not sure how much more we're going to learn from that one. And I mean that with respect. I don't mean that you're wasting your time. It's not my thing.
Yeah, absolutely. Well, and for what it's worth, it's the only one I have so far.
Yeah. Yeah. You'll get access to more. I mean, look, I understand that it's exciting to dig in and do all this stuff. For me, it's not, I don't share that excitement, I guess is the easiest way to put it.
Well, and look, to the other point, I'm not going to pull up the quote, but you were explaining why it is that I may have struggles in trying to connect with some of these other scientists. And I think that this kind of gets back to the meta conversation we were having earlier. In 2016, right as my research was kicking off, right as I had the inversion pattern in hand, and it was so exciting. And I naively thought it was just going to be snatched up and taken away, and then it'd be like, thanks, Dave, we're going to go ahead and take it from here, and then everything would snowball. I had such a tough time connecting with anybody, even at like a mid-level, particularly in lipidology. And now I'm having a lot more access, a lot more conversations, and I don't think it's because my data changed that significantly from what it was before. I think what it comes down to is there's more and more social media credential, I guess, as opposed to actual credential that you would typically get from university and so forth. And to whatever degree that's allowed for that access, I appreciate it. It shouldn't work that way, but it appears that it does. It's one of the factors that's end up ended up helping me get more access to be able to move this research forward. And maybe that's just what it takes. The downside of that is a lot of that gravitas comes from challenging the existing patterns, particularly in the area of risk. People are very interested in understanding, where I stand on risk. And no matter how much I want to be nuanced about it, a lot of people will oversimplify it. And that ends up becoming kind of a problem, because I'd rather they not oversimplify it. But
what do you mean about risk?
For example, I think it's very possible that LDL may turn out to not only, it's not whether or not it's benign or detrimental on its own. It's whether or not having metabolically high LDL may actually be associated with greater longevity. That actually you will have lower all-cause mortality with higher LDL if you have the triad. I think that's quite possible.
Yeah, I mean, this goes back to what we were saying earlier. Everything is possible until it's not. And I think it's an interesting question. And I think there are lots of reasons to want to answer the question. I don't think it's a stupid question. I don't think this is the dumbest thing I've ever heard in my entire life. Why are we wasting our time here? LDL is toxic and poison, and you should kill it no matter what. I think the question that we talked about at the beginning, does LDL in the context of all these other things, good things, mean the same thing as it does when it's, everything's bad? And the second thing is there something different about the LDL that occurs as a result of these nutritional changes? And this just comes down to how you and I would behave in a casino. I'm obviously more risk averse. I see this as, hey, look, there's a huge body of literature and evidence out here that paints a picture that, LDL is, I don't know what you want to call it, dangerous. And yes, there might be something different about this case, but what do we do? And from my perspective, this is really ultimately what it comes down to, is that I think this conversation often gets framed as a false dichotomy, which is you have a choice of either low carb, high fat with a high LDL where you're going to die, or you have to change your diet and do high carb, low fat, and you won't die. And we both know that that's not true, that there are several things in between that are viable options for people. And I think if at some point you want to say, okay, look, I'm willing to understand that there's risk, and that risk is risk we won't understand for a long time, but I'm going to accept that because I love this diet. I love the way it feels. I love everything else that's going on in my life. And maybe what I'll do is even try and take a more detailed look at all these other markers that I can measure, coronary calcium or CTA or other things, to make sure that I'm not messing things up. I'm not just going to close my eyes for 30 years and hope I don't have a heart attack. But I think the point that I've been trying to make is there are lots of ways to potentially mitigate the risk short of stopping the diet or taking a statin. And that's sort of the way I've been thinking about this, just in a sort of global sort of risk assessment way.
No, I think you're right. This is kind of the joke I make a lot, is I already have the cheat codes. I got the cheat codes back in 2016. I could right now, in 3-4 days from now, I could move my LDL-C to 130 by just having my carbs up at around 100 grams a day. I would swap out fat calories, swap in carb calories, and that's about where I would be at. And for most people who come and they say, I don't really want to discuss risk. I'm really just interested in how it is that I lower LDL without even trying to talk them into one direction or another. I want to help everybody who comes to me with wherever their position is at. And to that extent, if they're wondering what the best way is, my true sense is the best and most reliable way is to just be powered more by glucose and powered less by fatty acids directly. And you don't even need to go high carb, low fat, per what you said, per what I'm saying right now. I'm saying 100 grams of carbs, that's actually still technically low carb, maybe at the upper end of low carb. But if you still want to operate a lower level, I can understand why you may be interested in the deeper subject of risk, especially as the data applies to you right now. It's just
Danielle, I think Danielle Ballard is this cardiology fellow who we both have been interacting with a little bit, who's, very staunch vegan, plant-based person, did this little experiment where she did 2 weeks of vegan keto. And I think she demonstrated very nicely that you can do this. I mean, her lipids were already ridiculously good, but if anything, they improved a little bit. I mean, they didn't really change in a statistically significant way, but they certainly didn't get a lot worse, which is really interesting. And I think it shows a path towards, hey, look, you can actually potentially have both, where you can have all the benefits of low carb, all the benefits of whatever that comes along with that, and also not have a sky high LDL. And that's something that I feel super strong about. And I think if that's, and again, no one's going to force anyone down that road, but I want to demonstrate to people that you can actually have both.
Right. And for what it's worth, I think this is something I've wanted to investigate. Both her and, of course, Carrie Diulis.
Yeah, of course.
They both have very low LDL while also being keto. And it's the vegan keto. And I'm interested in how much of that is fiber versus mono and polyunsaturated fatty acids.
I think it's that I hate to interrupt, but I think you're hitting something that's super interesting, and these are areas that I want to study going forward. So fiber is one really interesting question. If you ask Rob Lustig, he'll tell you it's all fiber, but I don't know, maybe it's fiber. The other one though that I think is just not explored, and I don't know how you do it in the most scientifically rigorous way, is what you were just getting at, which is the saturated fat versus replacement with monounsaturated or polyunsaturated fat. So the unsaturated fat, saturated fat dichotomy, and the problem is you don't know if it's saturated fat is causing whatever you want to call it, increase in LDL, and it's just replacing it with something else that causes this, versus it's the addition of the unsaturated fats that's actually lowering the LDL. That to me is an unanswered question. I think there's some hints, but that one to me is super cool. I love the replacement.
You want my theory?
Yeah, tell me.
My theory is PUFA rules the roost on that one. That actually polyunsaturated fatty acids have a substantial impact. And it's from a dose-dependent standpoint, I think it wouldn't take much. The problem is that it's very hard to isolate MUFA monounsaturated fatty acids away from PUFAs. They usually as buckets go, you're typically getting more on the saturated fat side with much smaller amounts of MUFAs and PUFAs, or you're getting a lot of MUFAs that come with a decent substantive amount of PUFAs. So take olive oil. Olive oil is what, 2 to 1, I want to say, MUFAs to PUFAs?
Yeah, something like that, yeah.
So it's tough to disentangle the MUFAs and check it directly. But for what it's worth, those are the 2 experiments I have lined up. I'm going to be doing one experiment where I'm eating exactly the same way, because I'm me. I'll be doing 15 days of like a 5-day washout of exactly the same thing. And then a calorie swap where I'm swapping out the saturated fatty acids for a little bit of PUFAs. And I want to see how much of an effect that actually has against, and I'll actually be taking my lipids every single day.
So wait, you're just doing a 1-for-1 swap of SFAs for MUFAs?
Yeah, or for PUFAs. I want to do PUFAs first.
Sorry, PUFAs. And it's 1-for-1?
Yes.
And what are you going to go, how low are you going to go on the saturated fat?
I don't actually want to go that low, because I want to see a fairly substantial effect size, which I think I'll get with, let's say, a swap of maybe 20% or less. And what sucks is, in order for me to do this the way that I want to do it, it's probably going to be some kind of oil, probably mixed with my water, that I'll have to drink with my food. When I do, I don't know how much you follow my experiments, but when I do these experiments at this point, I'm now to the point where I always eat at the same times each day. It's always the same baseline diet, so it can be compared. My washout periods can be compared to prior ones. And that way, when the intervention hits, it's very clear where the intervention changes. And I try to get blood work at the start of the phases, of all 3 phases. So I'll be doing that on top of getting the cardio check lipids at the same time.
Cool.
One quibble I still have a little bit from that email, because you made so many great points in that email.
No, quibble away. This is what this is all about. This is basically therapy. Go for it.
Is I think what it was is, let me actually read.
By the way, I can be a huge asshole. I just need to be clear on that. I recognize I have some self-awareness.
No, I reject that. You're not. Okay. What I think I need to bring you up to speed with is, I'm an engineer and I've worked with engineers. So Believe me, we rule the roost on the asshole load. So you said, be very rigorous with your methods.
Yes.
If I'm being honest, so far you have not done that. Now, I think that point's well taken with regard to crunching data. doing things like assigning confidence intervals and so forth. I don't do that to the same degree as a typical trained scientist would, right? I'm definitely much more open in the process of putting data forward. And even though I try to caveat over and over again, it's preliminary, et cetera, there's that being on one side. The other side of it is I'm insanely rigorous with my N of 1 experiments. And oftentimes in the process of doing it, I learn more and more why it is that I can't trust a lot of studies that try to elucidate the same data. So for example, when estimating food, particularly not just with myself, but with my family, I feel like people's estimates of food are way, way unacceptably off. And so things like food frequency questionnaires have meant less to me than they ever have.
Coin flip, yeah, at best.
But on top of that, even to today, I now have a kind of game that I play with myself where if I'm about to weigh something, if I'm about to weigh the food, I try to actually do my own test of trying to estimate it as best as I can. I actually have a little, for anybody who cares to try this at home, I actually have a limped wrist kind of thing where I have to kind of feel if it's about an ounce or an ounce and a half or 2 ounces. And I try to guess before I put it on the scale. And I'm still impressed at what kinds of foods I can be completely off on. Like cheese took me forever. I so commonly underweighted cheese until I actually was doing it a lot more often. But this is a problem because oftentimes people already have a natural bias in that they want to, at least I certainly find this with my family and I hear about this a lot, they want to overestimate the healthy foods they're eating and underestimate the unhealthy foods. I don't know how you guys on the clinician side deal with that because that's got to be frustrating. But on top of that, when it comes to things like food logs, they're just more likely to leave things off. And
food logs are terrible. I agree. You're not going to get an argument.
Yeah.
And by the way, this is like, what I said to you was incredibly elitist. Like, who am I to tell you how to practice science? But I will tell you that the practice of science is something to this day, and I've been doing it for 20 years, that I feel incredibly unsure about. I think having not gone to graduate school, I feel very naked compared to my colleagues around here in this building, who I think have a firmer grasp on basic fundamentals of science. And I've been trying really hard to take care to do the right thing in the practice of science, because it is much harder than it looks. Much. It's part of the reason why I've gravitated towards doing mouse experiments for the first part of my career, because you can control so much there, and you can decide on statistical power, and it's relatively easy to increase the sample size as compared to human studies. Unfortunately, a lot of the stuff that we're interested in the mouse is not a great model. So we're moving towards doing more human-based studies too. I think if I could go back and de-assholify my statement to you about being rigorous in your methods, I guess what I would say is I don't ever doubt that you have rigor and you take a great amount of care in what you do. I think sometimes the experiments you do probably are, I guess the way I would put this is they're probably underpowered to have a lot of meaning just based on how you do them. I mean, I think it's really interesting what's happening, and I think the N of 1 experiments that you guys all do are really interesting, and I've done a couple of myself, and it's fun and great and everything. I'm just not sure how applicable that is to the sort of world of human beings outside of you and me and whoever else is doing our N of 1 experiments.
First, your emails are just gold to me. I should tell you, I've actually reread your emails 2 or 3 times. And it's because you were taking the time to write me quite a lot of words to outline your thoughts on this. And I definitely took it in the spirit of what it was meant toward. You were trying to emphasize what the environment is and for me to better kind of understand it. And listen, Ethan, it's got to be stated. If I don't state it enough on my own, a lot of people project expertise onto me that at the beginning of Peter Attia's podcast, I said it myself. I'm not a formally trained biochemist. I am not a medical professional. I absolutely confidently say that, look, this is self-directed learning. And as you said in the email, most people who have done a graduate program and had a lot of time post-doc, they have a whole lot of core knowledge that I'm going to have gaps in. No question. The reason that, and this is what's going to lead me to the other part of this, the reason that I think there's a lot of people who are paying attention to my work, including me, is that
And me.
yeah, is that these N of 1 experiments, they have the value of getting replicated instantaneously, and they do. So the original Feldman protocol from 2016 has now been replicated by over 200 people. That's crazy. These are all completely different individuals that have done this. And granted, it's not a perfect success rate. I think it's around an 85% success rate. And that means there's a 15% failure rate. But the fact that there's an 85% success rate is amazing, right? Like I feel confident, getting back to the casino, I'll bet you wouldn't bet me right now that if I grabbed a whole bunch of low carbers and we ate fat all through the weekend, that their LDL would go down at around an 85% success rate, right? Or would you?
Wait, sorry. You're saying if you took a bunch of people who have been doing low carb high fat for a long time, that
yeah. Let's say I took 100 of them. We went on a weekend in Hawaii and they consumed fat like crazy, and we drew their blood at the beginning.
Yeah.
I would bet you that, let's say 80. I would bet you 80% of them would end up having lower LDL cholesterol after the weekend is over, and that's an informed risk, right? That's something that I already have all these prior experiments to draw off of, including the KetoFest cholesterol experiment, where we actually did that live.
And when you say fat, you mean saturated fat?
Yeah, I mean, well, whatever their diet was, but multiplied. So even if they were having more PUFAs and MUFAs, I'll bet it actually would go down, relatively speaking.
Well, you'd expect it to go down because if they have a lot more PUFAs, right?
Yes.
Yeah.
All I'm saying is it doesn't matter whether it's saturated fat. I don't think it matters whether it's monounsaturated fat or polyunsaturated fats. As they all go up, the LDL would likely go up.
I see. Yeah, maybe. Yeah, I would not be surprised if that was the case. I'm not sure that means a whole lot to me.
Sure, but it means a lot to me on the energy model side because it seems to be more potential evidence towards the fatty acid trafficking. And
okay, let me ask you a question. Let's say I take 80 of my friends or 100 of my friends and we go off, and let's say they're all doing sort of traditional conventional keto with relatively high saturated fat. And let's say all those people have high LDLs to begin with. So we call them lean mass hyperresponders. And that we go off for a weekend or a week and we cut out all their saturated fat and replace it with mono and polys.
I think it goes down because
Okay.
I think polys and monos may be to a degree. I don't know, but the polys I think rule the roost. That's my working theory right now.
Yeah, I think you would not get an argument from a lot of people on that, but I don't think we have a good picture of how cholesterol biosynthesis is regulated from that standpoint. I think there's a lot. I mean, there are some interesting replacement studies that have been done, but that's an area that's ripe, in my opinion.
I agree. Actually, this is a place where I've had some disagreements with people who you're familiar with, but I think ultimately there's just a greater deal of recycling that's in play when there isn't as much demand for the synthesis itself. I don't think lean mass hyperresponders are synthesizing cholesterol day after day at the same multiplicity. I think that there's actually a lot of recirculating of the cholesterol from prior lipoproteins that have come out.
That's testable.
What's that?
That's testable. We've discussed it before. That is testable.
Yes.
Doing the kinetic studies, and I think, as to go back to what I said before, there are a lot of people out there who really do want to do these studies. And I think it's important to understand because you could begin to build even a stronger case short of outcomes trials that, if it were, if the kinetics were favorable, that you might offset the risk, right, of high LDL if it looks like they're not sticking around for very long. But if the flip side were true, that it looked like clearance were messed up, then you might get a little bit more nervous.
Can I broach the subject of whether or not we're looking at reverse causality from another standpoint?
Sure. I'm always a fan of looking at reverse causality.
Okay, so how much are we actually observing the character of the lipoproteins as causal versus what I think is more likely that they generally are reflecting the problem, that the lipid profile itself is reflecting the problem that's in the existing system. So
yeah, this is where you're going to lose me, Dave.
Okay.
I mean, because this is where go back to the animal data, it's pretty compelling. Like there's not I understand what you're getting at, that you think that it's inflammation that causes the lipid changes. I think the vast majority of evidence suggests it's the other way around, that the lipid changes cause inflammation.
That lipid changes initiate inflammation.
Yes,
Is what you're saying.
correct. Yeah.
So let me ask you this, because you may
Yeah.
know this better than I do. Do we have animal models where we know for sure that it's a healthy, functional vascular system, but we managed to boost LDL particle count substantially, and native particles, right? Like they're actually native to the animals
I
themselves.
mean, this is the question. You and I have talked about this before, and I think we get into this like circular reasoning problem sometimes. I don't know how you isolate the endothelium from the circulating lipoproteins. I mean, if you're asking me, can you make a mouse get atherosclerosis purely by having it overexpress a lipoprotein? The answer is clearly yes. If you're asking me, could there be something about the LDL receptor and its function in other cell types other than the hepatocyte that would disrupt the function of that cell? Yeah, it's plausible, it's possible. But there are multiple models, genetic models of animal-induced atherosclerosis, and not all of them are LDL receptor deficient.
Right, but what I'm saying is if we did, what would be the reverse of apheresis, where basically you're
Use it.
yeah, where you're basically infusing the native LDL particles.
Yeah.
I've not looked as much into the animal side of it, but have we done that where there's no genetic like knockouts or anything along those lines, where it's actually just a sheer exposure level?
Well, I mean, again, since most of these things are made and modified in the liver, and since it's a lot easier just to turn on a gene to then start making something in the hepatocyte, which is the cell. I mean, what we're talking about is making it a hepatocyte in dishes and then infusing it into an animal, which has been done certainly for ApoA1 Milano. I'm not sure. Actually, I would almost guarantee it's been done for LDL particles as well. And in fact, I think Brown and Goldstein did some really cool, what are they called before when you sew the two animals together? My brain went dead. These experiments where you basically, I can't think of it. Where
So
you
they
sew
share a circulatory system,
Yeah,
basically?
exactly. Yeah.
Yeah.
And they could show that it was the lipoproteins coming from one animal that caused atherosclerosis in a genetically normal animal.
I'm certainly interested in any version of like reverse apheresis in some fashion to a healthy vascular system. And I've asked about that before. You may know something that I've been able to get from my other sources and try and ask about it. Because of course I've tried to search for it and I've tried to actually ask some of the people who are on more expert side of it. But nobody had seemed to, like, for example, there's been versions where they've included, say, human LDL particles. I don't know why they went in that direction, but there's probably more logic. I was just saying, look, is there just native infusion of rodent LDL particles that are, native to those rodents at a higher concentration? I would consider it compelling data. I just state that up front. If it's a healthy vascular system, that would be a clear sign. It's just that it's got to be comparable. That's the thing.
I can tell you what, with strong certainty, it's been done. I mean, these were the experiments that people did back in before there was genetic engineering. These were the experiments that that people did. They were either diet nutrition studies or they were infusion studies. Parabiosis is the word I was looking for, where you sew two animals together. And I would bet, and when we get done, I'll go and look, that there were parabiosis experiments taking animals that had high lipoproteins, and they showed that those animals caused atherosclerosis in a wild type animal when sewn together.
So I'm not. I have to interject this. I would naturally want to see that they also captured inflammatory markers. If what you're describing right there, particularly if it's like post surgery, I would expect that there would be a healing process.
There's a control, right? So you set it up that you have sort of high LDL to wild type, high LDL to high LDL, and wild type to wild type. So you can compare. I mean, these are relatively easy to control for. So you compare for the surgery. It's basically a sham surgery. That's the beautiful thing about doing animal experiments, is you can do all that without too much trouble. But anyway, I don't know the literature that well. And actually, I am not a lipoprotein person. I'm not a lipidologist. I spent the first part of my career in thrombosis and wanted to understand everything there was to know about blood clotting, and I've spent the last 10 years or more trying to understand metabolism and insulin signaling and insulin sensitivity and the hormonal regulation of insulin sensitivity. This thing is just a hobby, and I like it, and it's important clinically, obviously, but I am not anywhere near an expert in lipoprotein metabolism.
No worries. Obviously, I'm not myself. I'm just working my way in that direction, or at least towards trying to understand it more. It's funny you mentioned that, though, because I have had some off runnings with hemostasis. And I've gotten kind of excited with a lot of things that associate with that and the clotting cascade, so forth, that really gets pretty fascinating. I'd really like to see a lot more studies on plasminogen, especially, and just the whole process behind that. I'd first gotten sparked because of a friend who was talking about, she thought she may have had some kind of stroke and that might be a TIA, and was at the hospital and didn't know what it was called at the time, but they said, we don't have enough time, given how long it's been, for you to get I think it was a CT.
Uh-huh.
So we're either going to get you this drug that,
TPA.
Yeah, it was TPA, right.
Yeah.
And they said, okay, if it is a clot, then this will help you. If it's hemorrhagic, then it won't help you. It'll actually make things a lot worse. And she had to just make a decision on the spot about it. And so she went with the TPA. And now I know what TPA stands for. It took a while for me to find out a lot of these things. But the whole process is so fascinating because, as I'm sure you know, our vascular system is constantly getting injured and rehealing in many different respects. And we already have that primary version of hemostasis to take care of it constantly. But then to some degree, secondary comes around, and then there needs to be a whole lot more things involved.
Yeah. Look, I mean, it's still on my wall. Even though it's been 10 years since we published a paper, but I never get tired of looking at this baby.
Yeah.
Yeah, it's a cool system. I mean, it's a really cool system, and if you care about engineering and you care about evolution, it's an even cooler system, because you have to build a system that can respond very quick. I mean, basically, if you think about it, right? If you're an animal that has a blood system, that has a circulatory system, you have to be able to sense injury and repair it very quickly.
Yeah.
But the match between sensitivity and specificity there is so important, right? Because if you have an overactive system, you'll get a stroke or a heart attack, you'll clot off. And so the finely tuning that and making it responsive in a timely way, but in a specific way, is one of to me, the feats of mammalian biology. Very cool system.
Yeah, I have to tell you, one of the experiences that I had early on in this process was that I had no interest. I don't know if you knew this. I had no interest in science or medicine or biology or any of that. I was really all about writing code. And I especially got interested in when we were working very, very closely together to set up these big networks for the prior company I was in. And we eventually got bought out by a gambling company. And those platforms are extremely complex. And then when I finally, through fear, really, through my initial cholesterol test, suddenly had to start learning about lipidology, I was like, oh my God, this is a feat of engineering unimaginable. Like we're not, I feel like we're so far away, surprisingly, given how far we've already come. Like there's so much work to do to try to parse a lot of these things out. But the interconnectivity of all of these different systems is amazing. And I couldn't help it. I really was fascinated by the vascular in particular. The reason is because you need a lot of engineering mentality to deal with this problem of scarce space. There's, you have this freeway throughout your body that really has to keep the lanes open all the time.
Yeah.
And yet it's the means by which your cells are getting what they have to get. So from a complexity standpoint, for us to be these multi-cell organisms running around with just these massive complex organs within and so forth, it's a serious issue. And so, the reason I was in hemostasis was because I was especially interested in, after a problem occurs, how the real true process of regeneration of tissue happens, because that seems so challenging, so hard to pull off, right?
Yeah, well, not many tissues actually can regenerate. So, obviously the brain and the heart can't. There's some idea that you'd be able to stimulate regeneration. A lot of people are working on that. Not an area that I pay too much attention to, but a lot of people would love to be able to regenerate dead or dying tissue.
Well, I mean, certainly something like, limbs, we're far cry from that. But yeah, there's obviously been some data that's come back on, say, stem cell usage. And I think there's some Central America place that a lot of people are going to. I think I saw on a Joe Rogan that Mel Gibson had actually gone to one of these places, and it like fixed his shoulder. He had some like persistent injury, and it was amazing. It was just basically some kind of an infusion that had to do with stem cells that actually worked out pretty well.
Well, or it was a really fantastically expensive placebo effect.
That's possible too. Placebo, I feel like, doesn't actually get enough study. I think placebo effect, like actually studying in a more scientific fashion, it should really get a lot more attention, because we could learn a lot more about what's going on internally with us.
You and I both love podcasts, and there's one, I think it's Hidden Brain. There's an episode on the placebo effect that was one of my favorite podcast episodes I've ever listened to. And they talked about this orthopedic surgeon who was doing operations, and everybody believed that this, surgery, I think it was like arthroscopic surgery to repair meniscus tear or something in a knee, that it was going to make people better, but no one had ever done the proper sham controlled surgery or trial. And he did one where basically they would put the arthroscope in and just like stand there and sing for half an hour and like randomize people to actually getting it fixed. And I think that trial was like landmark. It was published in the New England Journal back in the early 2000s and showed that this surgery was basically no better than placebo. Now, what was interesting was placebo was better than nothing. And I don't remember the magnitude, but there was definitely an effect of somebody thinking that they had had surgery. And so I think the more we learn about it, you're right, there's a fascinating effect of placebo. Placebo is definitely real, no doubt. And for people to say that something is no better than placebo, I think ignores the fact that placebo is something.
I agree. Actually, while we're on the subject,
sure,
I really wish every single thing that had a placebo arm was required to have a true placebo arm. That's actually one of my other complaints with a lot of cholesterol-lowering medication trials now, is I really wish there were still true placebo control arms. And I realize that there's going to be a discussion on, whether it's ethical and so forth. Because
you're talking about as opposed to like on top of statin.
Right.
Yeah, that's that ship sailed, Dave. Look, and you could have that same conversation in the thrombosis clinical literature too. There were plenty of drugs that were developed, and they had to be tested on top of the existing therapies. And look, as a scientist, I hate that. As a physician, it's harder to ignore. It would be very difficult to do a statin trial, especially in secondary prevention today, in high-risk people, to do a lipid-lowering therapy trial on a placebo background. I think you'd find a lot of pushback at the IRB.
Yeah, I definitely agree with you that everything I've come to understand is that ship really has sailed.
It sailed.
But that said, as far as from a scientific standpoint, I mean, to me, it's an oddity, because I feel like unless you could have a level of certainty that, you would have for, say, the Earth is round, that you could feel confident, the majority of scientists are never going to change their mind on it, no matter what the data comes in.
Yeah, but the issue is, it makes it, I mean, in some sense, look, I totally agree with you, and from a scientific standpoint, it would be great to have, but it raises the bar. It makes it harder to see an effect. I mean, if you're already starting on somebody who's on a background of a max tolerated statin and has an LDL of 50, and you have to show an improvement beyond that raises the bar even farther. Like that makes it
right. And look, this is the problem. This is the problem in a nutshell. We don't know how much of an emotional impact it has on people to get their lipid information back. Yeah. We don't know how much of an impact it has on their doctor that's seeing them and how they're treating the case, right? And this is why, here's the other ship that sailed. This is why I think the only real way you could do a truly double-blind placebo-controlled trial on statin data is if the lipids were blinded from the patient, the trialists, and their doctors. Right?
They were.
Oh, okay, so this is in the earlier ones from the 90s?
Yeah.
Oh, okay.
Yeah.
But are
Yeah,
they
no one had any idea what the lipids were. I mean, there were probably people who could tell based on what the blood looked like, but no, they were all blinded. Everybody was blinded.
okay? Because
Yeah.
I've been told that they weren't truly blinded. That is as far as in terms of the
Mm,
no.
Not unless I'm completely missing something. No, of course not. I mean, you would then be, I mean, you would be, it would be an unblinded study. I mean, you'd know if you were doing a study comparing simvastatin to placebo and you and your doctor both saw that your LDL went from 140 to 60, you'd be unblinded. I mean, you couldn't know
Yeah,
that.
this
So
is
I
why I don't spend a lot of time on the statin side of the fence. But
Okay, but I want to come back to this one before we finish because I think this is really important. I want to state clearly why we, I won't speak for anyone else, why I am so enamored with drug trials, why I find them intoxicating and very difficult to ignore, and why I love them so much, despite all the warts that we've talked about. And that is that they're the closest we're going to get to having purely randomized, unconfounded populations where you can isolate a single variable. In this case, not the change in LDL, but the presence or absence of an active drug. And that to me happens so infrequently. So it just like tickles me as a scientist to be able to do that kind of an experiment where you can compare two populations of people that are relatively similar, not identical, but similar, and that there's only one thing different between them. And that is this group A gets a drug and this group B gets a placebo. And that's why I'm fascinated with them and don't want to ignore them, because I think it's the purest and cleanest science that we'll get in human biology.
okay, but I do have to throw a caveat in there. As
Go
you
for it.
well know, drugs don't typically do only one thing. In fact,
Sure.
that's one thing we were talking about before, in that you like to call statins heart attack prevention drugs, not
Correct.
necessarily LDL lowering drugs, right?
Correct.
And
Yep.
this was in the context of one of the discussions we were having is I was bringing up that if it were true dose dependency and we were looking only at drug trials, then all drugs that lower LDL would have a likewise reduction in effect of heart attacks, right?
Well,
Uh,
no, oh, come on. If you had a drug that was laced with cyanide, it, if it was compounded with cyanide, it would not be expected to reduce, right? You,
but your mortality. Well, is that's what you're
well,
saying,
you'd be
right?
dead before you'd have a heart attack. Yeah, there are drugs with toxicity, with off-target toxicities. There are drugs that have been developed that happen to lower LDL. There are other biological examples of times when your LDL is low. You mentioned one is cancer, where you're really sick. Uh,
Right.
so no, not all LDL lowering is good. I've never said that, never would. And I definitely agree with you, as you were parroting me, that we can say that statins lower LDL and statins reduce risk of heart attack, but that it's not 100% linked. That is the reduction in LDL to the reduction in risk of heart attack. I happen to think that it's strongly linked, but I am more than willing to allow that I think there are other pleiotropic effects of statins that confer benefits beyond the LDL reduction. That is
Which
100%.
which by the way, I feel like is the pitch if I were in your shoes to give to the person who has the super high LDL who you're worried about. If you're so if you're saying, look, I would still prefer you to be on a statin because it's not where your LDL is at. It's because I feel, even if you feel that statins can only work from pleiotropic effects, go ahead and just accept the pleiotropic effects, right?
Yeah, that's exactly right. In fact, that's why, I mean, the guidelines in 2013 went away from looking at LDL levels at baseline or even with treatment as a way to make a decision on whether or not to use a statin. It was all, now your LDL level by proxy was included in the risk calculator, but the risk calculators were an effort to try and steer people away from over focusing on LDL and to look more globally at risk. Now, people didn't like that for a variety of reasons. So LDL is now back into the discussion.
Right. With it, well, and of course, 190 is now the qualifier by itself. Like you actually don't, if you have an LDL of 190 or higher, without any other qualifiers, the guidelines say you should be on a maximally tolerated statin.
100, you're absolutely right. I think it's basically equivalent. It's considered to be equivalent to FH.
Right. Which, yeah, obviously we'll have different opinions on possibly, but but getting back to your main point, I agree with you in that I can appreciate the ability to actually do something in a randomized way as an RCT can do. And that's what drug trials can do and have humans as opposed to animal models. So we actually have a comparable system. It's just there's no getting around it unless we had a lot more funding that went towards the public sphere to, like, I would love it if there was just a lot more random reproducibility of existing drug trials. And then that would help to also keep the drug trials aware that
We'd all love it. We'd all love, you know, comparisons. There are all kinds of things we'd love to see. As you mentioned, we'd love to see real placebo-controlled trials. The problem that comes back every single time we have one of these conversations, the problem is going to come back to how you pay for it. And right now, the model that we have in this country is that the drug companies do the R&D, they pay for the drugs to be developed, they pay for the trials. In the vast majority of the occurrences, that's the model. Is it a good model? If we had it to do over again, might I design it differently? Yeah, of course. But there are definitely some government-sponsored trials, 100% certain, and I think they look pretty similar. And I also think, like, although I've never been on, you know, a clinical trial, I've never done a, you know, real big industry-sponsored trial myself, and I've never been in the room there. I think, with a few exceptions, most of these people are really good people, and they want to do well for science and really want to do well for patients. So I think there are very clear examples where that goes off the rails, but most of the time I think people are well-intentioned.
And I agree. Like, if I want to be sure that it isn't lost, that I believe, as far as across the board, everybody on the medical side, everybody on the scientific community side, yes, there's some bad apples in all of these groups, but they are few and far between. I think most people really mean to do right by not just their patients, but hopefully for the science itself.
You should, just for fun, if you haven't looked at it, look at the heart protection study, which was this, you know, UK sponsored, not NIH, but UK sponsored study of 20,000 people with coronary disease, secondary prevention. And this one was actually hit an all-cause mortality benefit.
Yeah, in fact, I'll go ahead and link it down below as well.
And that one was not sponsored by any companies.
That was publicly funded?
Publicly funded by the government of the UK.
Great. I mean, if it's good methodology, I'm going to love it.
We're always going to. It's great. The beautiful thing about science is that it's always fun to poke holes. Like, it's part of, like, the process, right? Like, if you're a good scientist, you're always going to ask really good, hard questions. And I think probably we haven't been asking hard enough questions. And in fact, I bemoan the fact that we can't have civil conversations like the one that you and I are having anymore. And that what it's turned to, at scientific meetings at least, is that people just don't even ask questions because they're afraid of what's going to happen. I mean, in the old days, back in the 70s and 80s, I heard stories about people just literally screaming at each other and throwing things, which is probably extreme on the one side, but at least we were having a discourse. And I think if there's anything I can say, is that we need to have more conversations like this, where we educate each other, listen to each other. Don't come to it, I'm speaking to myself as much as I'm speaking to you, don't come to it with a preformed dogma and an agenda, but try really, really, really to listen.
Yeah, so I couldn't agree more with everything you just said. And I really, this is a pretty good place for us to wrap. We're actually coming close to your hard stop anyway. I just have to say, I'm very thankful that you took the invitation, that we were able to really talk about it. I mean, it's sort of funny in many respects. This conversation reminds me of conversations I've had with a lot of engineers, that we came to the table anticipating that we'd have more things we would be disagreeing on. And then actually, because we were already in the mood to really kind of hash things out, what do? We end up finding a lot of ways to empathize with each other. And I think that's what's needed more than ever, especially with the low carb community and with doctors, and especially just with nutrition overall. This is really kind of an exciting time if you think about it, because we've never really had such an ability to share information between groups so readily and so quickly. And yeah, there's some downsides to that as well. But I think at the end of the day, a lot of this comes down to being willing to reach out outside of your community and constantly check yourself, challenge your own core beliefs, and see if you can keep a scientific mind on about it, not just on, day one or year one, but for the rest of your life.
Yeah, well, and I commend you for that. And it's been really fun to participate in this. And again, I think you said it at the beginning, but it's worth repeating. I'm on the inside here. Like, I'm a believer in in low carb. I see I see this conversation we're having as being the single most important thing to low carb nutrition. And I think I probably have a very different take than almost everybody else in that world, uh, and probably not a very popular person in that world. But I am very much of a believer in low carb nutrition, very much.
Well, you're certainly a popular person with me. So, how do people find you?
I mean, I guess the place that I spend the most of my time is on Twitter. I'm at Ethan J Weiss, but I'm all over the place. I'm not too hard to find. People tend to find me. I'm always amazed by how easy I am to find.
And I got to once again just straight up plug your podcast. I think it's just amazing. You're a fantastic interviewer,
Thank
and
you. I appreciate that.
you're lining up some great guests too. So
Well, it's been really fun. I think, one of the sort of advantages of doing what I've been doing for a long time is I've made great friends. And so now I get to kind of call on favors of these good friends of mine. And so it's been fun because everybody I've interviewed so far, with a couple of exceptions, are people that I know really well and have already kind of really good, strong pre-existing friendships with. There have been a few kind of that have been people I've just gotten to know. But it's been a fun process, and we're going to continue. We're taking a little break right now. We're going to start back in the fall, and we have some awesome people lined up. So thank you for plugging that.
absolutely. Well, then otherwise, I hope you have a good weekend, Ethan, and I hope we get to do this again.
Let's do it soon. Thanks, Dave.